Hello, Caesar. I can't
Hi.
see you.
Sorry, I was having some issues with my computer here, so I just changed my
No problem.
mobile phone because for some reason the sound's not working my computer.
Good evening, Dr. Vivek.
Good evening.
We'll start in a couple of seconds, just around 15 to 20 seconds. Sorry. Hello, Dr. Mankad. Hello, Dr. Rashmi. Dr. Kamte, good evening.
Hi, everyone. Hi, Dr. Nihaal. Hope you're well.
Hi. Yeah, all good. Thanks. So I think we have, Dr. Vivek is there and most of our panelists are there, so we can start off with the session. So once again, welcome everyone. I'd like to thank our panelist, Dr. Mankad, especially tuning in from Cyprus. He was in Spain last week, but still he joins us and shares his knowledge and expertise. Kisa, who's on call and still joining us, thank you again. Dr. Walthauser, thanks again. And hopefully we'll have Dr. Vijesh too. We have around 11 cases, new cases and 2 follow-up cases. So we'll go right ahead with the first case from Dr. Vivek.
So this is a 2-year-old boy who had always had mild delays. So parents were not that concerned about his delay. He was an ambulant child, more of a speech delay, and maybe probably performing 6 months behind age. He had an episode of febrile illness in which he had a focal seizure and was encephalopathic for few days, recovered, and he was well again. And then had a similar event this time for which he came to us. Focal seizure for a few minutes, then drowsy for a day and high fever. And then over the next few days, he got admitted with us and he just improved. And there was a history of SIP death at 30-month age, who again had delay. And in the first acute febrile illness, the child died and the cause was not known. So this child had normal, lactate ammonia gas, ketones negative. His TMS was normal. We just recently got it. And his urine organic was normal as well. So there was no methylmalonic aciduria. And his homocysteine was high. So we had suspected intracellular cobalamin defect, possibly cobalamin C defect with the imaging findings.
Yeah. So. Yeah, thank you. So moving on to the imaging, on top we have the diffusion weighted sequences. And here you can observe that there are some asymmetrical, though confluent changes in the bilateral superficial deep white matter in the frontal regions, also involving the plex, the internal capsules and the bilateral globa pallidi. Coming down inferiorly, the mesial temporal lobes are involved on both sides. You can see also the amygdala is involved more on the right than the left. And there are restricted diffusion along the bilateral central tegmental tracts. Corresponding signal changes are seen on the flare sequences, again slight asymmetry in the right more than the left. No structural malformations per se, just the slightly asymmetrical abnormalities involving the white and the deep gray nuclei, temporal lobes, and also the dorsal brainstem. No SWA abnormalities. The undersurface of the corpus callosum demonstrated few patchy areas of high signal changes on the T2 weighted sequences. The corpus callosum is slightly reduced in size. Other than that, I cannot appreciate any abnormalities in the posterior fossa. Spectroscopy was done and cannot appreciate any diagnostic way. There's no lactate. The NA, choline, and creatinine are relatively normal, slightly elevated choline, but given that the child is growing, it is expected. Cannot see any other abnormal peaks which can be contributed to the diagnosis. So I thought, at least on the imaging pattern, changes if you concentrate on the global pallidi, these are the differentials to be looked at. Again, just the various differentials, if you concentrate on the bilateral globus pallidus changes. Given the homocystinemia,
then okay, fine. Okay, fine. You would take it. Okay, fine. Take it. ನೋಡಿ ಈಗ ಮತ್ತೆ ಗ್ಯಾಪ್ ಇದಾಗಲ್ಲ ಇವತ್ತು ಅಮಾವಾಸ್ಯೆ ಎಲ್ಲ ಪೇಷಂಟ್ ಹೇಳಿದ್ರಿ ಅದು ಮೀಟಿಂಗ್ ಸಾಯಂಕಾಲ ಸಾಯಂಕಾಲ ಇರ್ತಿತ್ತು ಆಕ್ಚುಲಿ ನಾಳೆ ಇರ್ತಾರೆ ನಾಳೆ ಒಂದು 5 ಸ್ಟಾರ್ಟ್ ಮಾಡಿ ಮಧ್ಯಾಹ್ನ 11 ಬಂದ್ರೆ ಕ್ಯಾನ್ ವೇಟ್ ಟಿಲ್ 5 o'clock.
Okay. Sorry for that. Dr. Kamte, I think your mute is not, I mean, you're not on mute. We can hear your conversation. So anyway, homocystinemia, since there was elevated homocysteine levels, possibilities of the hyperhomocystinemia, but I don't think it clinically matches. And there's no skin or eye changes to fit this diagnosis. So these are differentials we thought of, and at this point, I'll open the case for the panelists and others to comment upon.
Just a question. Why do you say it's not fitting with intracellular cobalamin metabolism disorder? Because you have fair hair, you have high homocysteine, you have seizures, you have recurrent and for at least one episode of encephalopathy. So all these things can actually fit in.
Okay. No, I meant the cystathione beta synthase and the MTFR reductase deficiencies.
What's the methionine?
Methionine is normal, I think. Dr. Vivek?
Yeah, methionine is normal. It's not low. It's not low. And it's not high.
Without treatment, is it?
Yeah, I started on hydroxycobalamin and betaine also. And we are waiting. I'm just in the process of convincing family to get genetic evaluation done. But yes, MTHFR deficiency would be a differential as well. Do you have?
You mean the homozygous variety? Homozygous variety, correct?
Yes, yes. The MTHFR, which we had seen in the first few years, they had presented more with hypomyelination, severe hypomyelination, rather than these diffusion restricted small molecule metabolic disorders. At least the 2 patients I have seen. Even though later in life, after 5-6 year age, patients have come with febrile encephalopathy, MTHFR deficiency with cortical damage. So globus damage with MTHFR, but that must be a possibility anyhow. But I haven't seen one, but that will be with high homocysteine.
No, I've seen 2 cases, but basically as far as I remember, they don't have this striking globus pallidus abnormality. I don't remember.
Yeah. So they've had more cortical or hypomyelination rather than globus.
Right.
I think it's more diffuse, but as Dr. Mankat says, isn't it the same pathway of cobalamin metal myelonic acidemia? Is that right, Dr. Mankat?
Yeah, that's right. I think you had shown it on your slide as well. It's kind of in the middle of that pathway, isn't it? So it's not a surprise.
Yeah.
There, that one, yes. Because I think anywhere along that pathway, if you have a problem, you will have these manifestations. How are you planning to treat though?
So to decrease the homocysteine, we started betaine, and assuming it is cobalamin C, we are giving hydroxycobalamin intramuscular because that's the activated form which would potentially work in cobalamin defects. So one ideally should only give hydroxycobalamin intramuscular.
And are you planning repeat imaging or just clinically following up?
So clinically, and more than that, with limited, often they have financial constraints. So rather than the MRI, I need to get the genetics done, So
yeah, sure.
Yeah.
I mean, some of these cases, the reason I ask is, you clinically they improve and you don't need to actually repeat imaging. But if we were to repeat imaging to even see if things are clearing, we could do some very short sequences. We don't have to do everything each time. And Nihaal will agree, for resource implications and time implications, as well as, sedation and other things, we could completely reduce the time to diffusion and flare only for follow-up if required to see if things are moving in the right direction.
Yeah, I'll agree with that.
There was a query, what was the reason for corpus callosal finding?
There is a list of things Nihaal can tell you about that can do that undersurface involvement of the corpus callosum. It's just telling us that there is a white matter involvement.
Yeah.
I don't think
Yeah,
that's
it's more,
any more specific than that.
Yeah, if it was just an isolated finding, then probably, but since it's also involving the bilateral hemispheres, predominantly the white matter, so I would take in consideration that's a white matter change. Though the undersurface can be seen in vanishing white matter, but this doesn't look like a vanishing white matter.
Thanks. So just for MTHFR, so the hypomyelinating patients, the first 2 years, if they come to me, I always do a homocysteine in them. Even though it's still not been reported, hypomyelinating syndrome due to MTHFR deficiency, I don't think it has been, but I've already had 2 patients and people are seeing more of them. So that's more of a partially treatable cause of hypomyelinating syndrome.
I wonder the use of hypomyelination might be erroneous in this respect. I don't know whether we have
Delayed myelination.
Yeah, I think they're mostly delayed myelination, and you need these vitamins for myelination to happen normally. So it may not be a strictly speaking hypomyelinating leukodystrophy in that case, which people show as examples, but I don't think that's correct.
So delayed myelination. So that's why we taught more of intracellular cobalamin, because this is more like a damage rather than delayed myelination. But then Nihaal has shown MTHFR deficiency can present with, rather than a delayed damage. So possibly that is also.
Yeah, but even in that, for myelination disorders, usually the diffusion is not so strikingly hyper. So this is again a damage cause. It's a demyelinating condition, but there is restricted diffusion. So.
Yeah, so 2 of my patients have 510 MTHFR, but they didn't have any diffusion restriction, just delayed myelination, significantly delayed myelination, first year of life.
Okay, so probably you'll get back to the genetics, okay?
Yeah.
Yeah, all right, thanks. Case 2, Geeta, if you're there.
Yes, this was a 9-month-old male child who is a known case of Down syndrome. So he came to our hospital for the colostomy closure. So it was an uneventful procedure, and during the in OT stay also the child was fine, and like post surgery this child had one episode of right focal seizure with a hypoglycemia, although he was on the IV fluids and all, and 1 hour later also second episode he had a right focal seizure without hypoglycemia this time. So later on during the course what happened, he had recurrent apneas for which he has to be ventilatory support was given, and for the stay he was like ventilator dependent, requiring many inotropic support with autonomic dysfunction. He had later developed persistent fevers, focal status epilepticus, prolonged encephalopathy, and prolonged ventilatory support. So, and investigations wise, first we had a workup for whether any infective or etiology. So we have done CSF and all, it was normal. And during this seizure episodes also EEG was done, but there was no epileptic discharges, but there was diffuse cerebral dysfunction was there. So later on in the course, after about 10 days of the hospital stay, Acinetobacter was positive, and previously he had this low calcium and vitamin D requiring the corrections and all, but normal PTH. Other metabolic workup was like normal, except this lactate mildly elevated 3.1. So this child, for the first imaging was done about 1 week into the illness, and second imaging was mostly for the prognostication of the child, because he was requiring the prolonged ventilatory support. For that we have done. So the 2 changes, like MRI changes, we want to know whether these changes are due to any acquired condition or is it a genetic, because next can you take over, sir?
Can I jump in about the history? what means post-surgery? What about the interval between leaving
It
the
was
operation?
almost it was in few minutes, like almost 10 to 30 minutes post surgery, sir.
So almost in the operating room. And
No, after shift,
are you
after
sure?
shifting.
Are you sure blood pressure and everything was normal during that operation? How long was the
Yes.
intervention?
Intervention was around for half an hour. But during the intervention, he did not require any inotropic support, or he was hemodynamically stable. All vitals were stable.
Thank you.
All right, thank you. To the initial imaging, this was done on 11th August. And on top, we have the diffusion various sequences. And you can appreciate that the middle aspects of the caudate nuclei and some lateral aspects of the putamen and external capsule and the pulmonary thalamic nuclei demonstrate restricted areas of diffusion. Some perisylvian region on the right side. The posterior fossa does not demonstrate any signal abnormalities. Coming down, the parieto-occipital cortex appears slightly bright with some areas of low signal changes on the ADC sequences in the subcortical cortical regions. On the T2 sequences, the basal ganglia are slightly hyperintense. Again, you can appreciate the hyperintense pulmonary thalamic nuclei and the subcortical hyperintense changes in the parieto-occipital or inferior temporal regions. Posterior fossa, there was no posterior fossa signal abnormalities on the T2 sequences. On the parietal images, you can appreciate that there is a hypoplastic pons. The corpus callosum is slightly reduced in size with a focal area of scarring or septation over there. No abnormalities on the SWA sequences. Post contrast, and there was no abnormal enhancement. Spectroscopy was done, and on spectroscopy also, I cannot appreciate any diagnostic peaks which are contributory to this case. There is some plagiocephaly along the posterior aspect, but other than that, nothing very striking. Probably a J-shaped cell over there. A week later, the scan is done, and you can appreciate that the changes of the diffusion are more localized to the global pallidi, and also some areas of the midbrain, including the cerebral peduncles and the posterior cerebral hemispheres. Again, low signal changes on the ADC, more along the globus pallidus and the inferior temporal and parieto-occipital regions. The basal ganglia are slightly more edematous than the previous scan. There is also some degree of atrophy progression from the previous scan. Again, a spectroscopy was done, and there was areas of lactate peak in the bilateral basal ganglia. There's slight reduction of the NAA. Parietal, there was no abnormalities other than the volume loss of the supratemporal brain parenchyma. Given that's a Down syndrome, the pontine hypoplasia is common. Arterial abnormalities can also be seen. Corpus callosum and midline abnormalities can be seen. The only question was, are these post-hypoxic, post-hypotensive, because though there's no history of hypotension and post-ictal or post-hypoglycemic changes, or given that the scan has progressed to the second, on the second scan to the localized to the globus pallidus and also involving the brainstem, is it a possible mitochondrial or an organic aciduria? At this point, I'll open the case for the panelists to comment upon.
Nihaal, was the cerebellum involved from the initial picture? Was it a bit swollen?
Maybe on the right, yeah. Here.
So what was the age, sorry, of the child?
9 months.
Right. So see, I'm not sure if I mentioned before.
Yeah, you did for the hypoxia. The
hypoxia. This is what happens when the hypoxia happens between 6 to 12 months. Looks very, very metabolic. Globus pallidus involvement, thalamic involvement, putamen involvement, and you know the substantia nigra in the midbrain. I'm not sure why that happens, but between 6 months to 18 months, if there's a 6 to 12 months, if there is a hypoxia, that's how it presents.
I think there's also change in the occipital lobes, yes, with restricted diffusion.
Yeah, there is.
But clinically, there was no history of hypoxia, sir.
There is no documented history of hypoxia by people, but there could have been hypoxia.
Yeah, intraoperatively, we don't know.
And this was soon after general anesthetic, right? If you go back to the first slide as to the timeline, because I think Eugen was asking about timelines.
Yeah.
Was that in the instant post-operative period, all this deterioration?
Yeah, yes, sir.
Well, okay. And by any chance, do you know what was used for induction of general anesthesia? Sometimes those agents can unmask latent mitochondrial disorders.
Okay.
Is the lactate normal, Geeta, or do you have a serial lactate?
Lactate is mild elevation is there, sir, but serial lactates and all, only one time it was 3.1. Otherwise, it was normal.
What was the OTP? Liver function?
It was normal.
Can I make a comment?
Yeah.
Yeah, please.
I was just wondering whether, I agree with this sudden stress producing these kind of things. I mean, hypoxia is of course possible, but in the OT, I'm sure they must be monitoring the oxygen throughout. So it's very difficult to unless there's that seems to be unusual. But a CSF lactate was done later.
No, we didn't do CSF lactate, sir. It was blood lactate.
I see. Because I think a mitochondrial disorder which has been unmasked by a stressful surgery is always possible.
So this child will be really unlucky to have two disorders. Actually, life doesn't go like this.
I agree. That's life. Sometimes you get both.
I think Nihaal and I are agreeing that it at least needs a baseline screening, unless somebody in the audience has more to add. And also the change in the 1 week between the two scans. And Caesar is right. Those occipital areas were involved in the beginning. I think the cerebellum was involved in the beginning as well, which would actually be a little unusual for hypoxia itself.
There was also hypoglycemia, though.
Wish I had, I might have them stored, but this is what exactly happened to two of my patients. And I did the workup. I did the whole exome, trio, mitochondrial signature, which was all normal. There was documented hypoxia in both the patients. At that time, I didn't know, I went through this path only. And then I realized that this is what happens with hypoxia between 6 to 12 months when this happens suddenly. This happens. This is how it happens with hypoxia, which has somehow not been reported maybe. But I already have had two patients. I think, Nihaal, I mentioned this before as well. Yeah. But maybe I will find those patients' MRIs if I still have them. And this is how it presents.
Yeah, I was thinking the same, not exactly the same, but the fact that it was occipital involved in bilateral in the history of hypoglycemia was just supporting the hypothesis of hypoglycemia.
Yeah.
And the evolution of the lesions are a little bit weird in the sense that we are seeing globus pallidus, as Nihaal said, it's quite common for PGH. Uncommon, it's too much white matter chains. We've seen some pathways of PGH like ECAGS1 may present with a lot of white matter chains and globus pallidus. It's an uncommon, but also the pathway of PGH. And the association of substantia nigra and globus pallidus is not as common as we see for hypoxischemia versus PGH. PGH normally at this age has a very, very, very high, it's possible that not the case, but normally they have a very, very high lactate peak. PGH among all mitochondrial disorders are the ones that we see for very high lactate normally in the spectroscopy. Not always. I also have case without lactate peak, but normally we see very high lactate peak, not small as these ones. I also think that's worth to look for mitochondrial disorders. I'm just seeing other chains supporting also hypoxemia plus hypoglycemia. So if you don't see change in the exome or in the mitochondrial genome, if you are planning to look for, I would just assume these things are related to the ischemia and the hypoglycemia.
Do you also need to monitor clinically? Do they stabilize for an hypoxic insult or hypoglycemic insult over a period of time rather than a metabolic one?
I want to add to the confusion. Of course, Kish is right that the cerebellar involvement makes hypoxia rather unlikely, but this is not an absolute argument. I have seen cerebellar involvement on patients on ECMO, for example, post cardiac surgery with cerebellar involvement. So this is not exclusive.
It's a very interesting case. Very interesting.
No, it's not. So the point is, at the end of the day, I mean, these tissues are going to have hypoxic ischemic damage, whether it's a primary or a secondary process driving it. I think I completely buy Vivek's point. The question is, do we have enough to say nothing else needs to be screened for and just call this hypoxic ischemic insult and just leave it at that? Knowing well that Downs is strongly associated with many other things.
I agree. Down syndrome is associated with mitochondrial dysfunction, right? So
Right.
as part of Down syndrome itself, you can get mitochondrial dysfunction, which might be unmasked because of the surgery.
Exactly.
Yeah, what I'm pointing here, I'm not seeing specific findings for mitos, but I agree with Kishan, with you. I think it's worth to look for a potential mitochondrial gene here, but I don't see specific imaging find that you can say, oh, this is certainly mito, not an hypoxemic injury. If I was seeing, like, for instance, instead of the globus pallidus, but lesions in the putamen and caudate with partial areas of restricted diffusion, I would say to you that's not hypoxemic injury. But features that I'm seeing here, I still think that's possible to be just hypoxemic injury plus other hypoglycemia, as you said.
Yeah, and
Geeta, what's
just
the
one more
plan?
point, Nihaal, before you move on. The time difference in the two scans is 7 days, right?
Yes.
When did the hypoglycemia happen?
5 days prior to the first cancer.
5 days prior to the first scan.
Yes.
Why do we have this diffusion restricting changes evolving in the 15 days or whatever following it? If it's all hypoglycemia, it would have been treated instantly, I hope.
It makes sense.
And also, this is child's second surgery. In the newborn period, also, he had one surgery for anorectal malformation and all, but that was uneventful. He didn't have any complication post that.
Yeah, that's okay. I mean, these are more recent changes, so yeah.
Because generally when we see hypoglycemia-induced diffusion changes, first of all, the detection leads to instant management and those reverse quite quickly. I don't know if it lasts for a week or 2 weeks in this case, as you're describing. And in fact, evolving over time.
Yeah.
Yeah, and just also to point that out, the SCGH, that's the gene that SCH1 would be the gene that you should target, is the nuclear gene. So you don't need to go to the mitochondrial genome in the beginning. You can just get for the whole exome, I assume.
Yeah. Geeta, what's the plan?
Yeah, we have plans to send the whole exome and the mitochondrial, sir, actually.
Great.
Okay. All right. Give us an update after you get the
Yeah.
results. All right. Thank you. Yeah. Next case, Geeta.
So this child was a 4-year-old male child with normal development, no perinatal issue, no significant family history. He had loose stools for 5 days without any dehydration, and then 5th day of the loose stools, he developed fever for 3 days, and on the day 3 of the fever, he had status epileptics. Like, it was a generalized seizures, almost lasted, like, they stay in a remote place, so it lasted around for 1 to 2 hours. And ultimately, he ended up with encephalopathy, respiratory failure within few hours. And there itself, the pupils were dilated and fixed. When he came to our center, his GCS was poor with brainstem dysfunction was there, and there was no motor response. So the first MRI was done on the 3rd day of, like, on the day of the status, sir. This is an outside MRI. So
Yeah, so the outside MRI on 16, diffused excitotoxic brain injury, predominantly only subcortical cortical regions, and also some areas of the left thalamus. Like, I cannot see anything in the brainstem or the cerebellum, but yeah, there is sparing of the deep and the periventricular white matter, but subcortical cortical involvement is seen on both sides with some areas of the deep brain nuclei involved over here. Yeah, Geeta.
Yeah. So during the hospital stay also, we just wanted to give him proper sedation, and we wanted to observe for any return of the brainstem reflexes. Like, but he was hemodynamically very stalled. He did not require any inotropic support, but brainstem reflexes were absent. And EEG wise, there was a diffuse cerebral dysfunction was there. So the second scan we had to do for the prognostication purpose. And also post that, we have done a CSF analysis, which was normal, sir.
Okay. Just on the first scan, there are some hyperintense changes in the bilateral cerebellar white matter, possibly also in the dorsal brainstem, which are not seen on the diffusion. Again, just similar edematous changes in the peripheral regions of the brain. Nothing on the angiography. Sagittal cannot appreciate anything, but there is. When you go to the follow-up scan, again, you can appreciate this diffuse excitotoxic brain injury, now also involving the spina of the corpus callosum, also involving the right thalami. There is a bilateral descending transtentorial herniation with possible posterior circulation infarcts on both sides. There is also the cerebellum is also edematous, low signal changes on the ADC corresponding to the diffusion changes on top. Again, descending transtentorial herniation, there is some inferior tonsillar ectopia on the coronals. No hemorrhage or calcification on the SWI sequences. We did not do an angiography for the scan for the child. Again, bilateral dentate nuclei changes. Thought of possibilities of ALRD. The etiologies can be varied from viruses to infections and toxins related changes. Possibly is a variant of the diffuse variant rather than the central sparing variant, which is seen in which is the central areas are spared over here, but in our case, it is completely involved. So the etiology is slightly, we don't know what the etiology is, but the imaging features are probably related to the ASD or ALRD pattern with areas with changes of posterior circulation stroke on the follow-up scan. At this point, I'll open the case for further opinions. What was the question, Geeta? Sorry, before we go to the panelists.
So what can be the etiology like?
Okay.
I'm thinking infection first.
Yeah.
Yeah,
Like presentation and all, and with the hemodynamical stable but poor brainstem reflexes, what might have explained? Like first scan, we didn't had much handles. No?
This looks more like a cytokine storm. Did we do H1N1 and COVID?
We have done COVID, sir. It was negative, but we didn't do H1N1.
Might be worth doing it because that's also increasing, and that can.
This is a
And
question.
how were the images contrasted at any point?
No. No,
Yeah,
contrast wasn't.
All right, okay.
Just a question: is it possible this is because of was the status very long? Because the the thalamus also is involved, Alvinar, especially on the right side.
Yeah. Geeta?
The status was around for, as per history, it was for 1 to 2 hours. Suppose that he did not had any seizures, even in our center or that center.
Right. But I'm saying that 1 or 2 hours is enough reason to have like an HHE syndrome. Of course, over here is bilateral, but maybe in a bilateral status. I don't know.
It was bilateral. Even we were thinking of that, sir, but it was generalized seizures, not focal seizures.
How old is the child?
4 years.
4 years.
You're talking about clinical seizures or electroencephalic EEG changes as well?
Clinical seizures were generalized. In the EEG, we had just diffuse cerebral dysfunction. There was no focal discharges.
So again, there's an interesting phenomena. Sir, Dr. Udani might also have things to say here. So this child at 4 is just as the cusp, the higher cusp of having HHE, because when you see it in children between 1 to 3 year age when they have status. Thalamus you see at all ages, but the HHE syndrome is more in children below 4, 3 to, below 3. And by 4 to 5, they start to have mesial temporal injury rather than the whole hemispheric injury. But yeah, that's.
You're right. I mean, you're right about that. But the problem is, these basically the changes which have been described are mainly from the Western Hemisphere. And if you see the evolution, HHE is almost gone over there. And the reason is probably because the status epilepticus in our country lasts for several hours, and that's almost unknown in most Western countries. So In the past, when there used to be HHE, even in Western nations, there used to be a lot of status for a long time. Now, of course, I don't know about the cusp, 3-4 years, it's a little difficult to be sure. But I just thought because of this pulvinar on the right side, this is typically what happens in status. Of course, the left side, the whole thalamus seems to be involved. It's a little odd, but.
The seizure must be definitely contributing to this image, but sir, what I meant was what I have observed that in the first few years, maybe by 3, if you have status, you get HHE, but after 3-4, when you start getting status, you get more mesial temporal sort of changes rather than the whole hemispheric. Is that
right? But that's what I'm saying. So those reports have mainly come since the time status has reduced in its severity in from other nations. I mean, we don't see HHE at all.
Or is it the myelination, which that's,
No, but this is mainly cortex which is involved. No?
Right.
The white matter is involved, yes, but also the cortex.
Right.
Difficult to say.
Slightly asymmetrical left-right changes involving the deep and white matter equals infection first until proven otherwise. You had a child presenting with fever, loose stools, and pretty raised white cell count from memory of the first slide. Actually, I don't know what the units are, but
No, it is just 4,650, sir.
okay.
Like
Our units are
not
different.
very much raised.
What's the plan, Geeta?
No, sir.
Panel
The child is no more, sir. He's
okay.
So post that we have done the CSF analysis, but it came out to be normal analysis.
Okay. All right. Okay.
You said the child is normal now?
No more.
No more.
Oh, no more. Okay. Sorry about that.
Okay. All right. Thanks, Geeta. Next case, Pawan, if you're there, you can present it.
Yes, sir. This is a neonate born to non-consanguineous marriage to primary mother with antenatally detected initially some hydrops, and later scans were showing more of severe oligohydramnias and PAH, and is a near term with 36 weeker with IUGR of 1.9 kgs. Initially, in view of respiratory distress, child was on CPAP, and on day 2, child started to have seizures, and NSG was done on the same day, which was showing periventricular flare and cystic areas in parieto-temporal region, and got an MRI scan in view of the same after 2 days, and it was showing.
Yeah, we go to the MR. So the MR changes, we have some areas of parenchymal hemorrhage in the right frontal region, but predominant changes in the bilateral periventricular regions, extending up to the subcortical white regions in the right temporal and parietal region. But yeah, predominant changes in the periventricular regions, and also some intraventricular hemorrhage, but the ventricles are not dilated. Some areas of ischemia in the bilateral cerebral hemispheres. And on the SWI changes, you can appreciate the confluent areas of signal changes in the bilateral periventricular regions and the deep white matter. Some microhemorrhagic foci also in the bilateral hemispheres. Some tiny foci in these cerebellum, and on the flare images, you can appreciate again these almost linear, like radiating pattern of changes on the flare. Given these, we thought of possibilities. This is a paper from Dr. Mankad, has co-authored, and these are the possibilities for the causes of neonatal ICH, thinking of the bleeding diastasis or premature related ICH, the possibility of infection. So these 3 were considered as a possible etiologies. Medullary vein thrombosis, given the area of involvement, was another possibility. And so after that, Pawan, we got hematological workup done.
Yeah, child was having a thrombocytopenia from day 2 of life. Not very severe, which was less than 1 lakh around, and mild deranged coagulation only, and PT of 28, APTT of 52, and INR of 2.2, and infection wise, blood culture was sterile, CRP was not much elevated, and child was also having on ultrasound bilateral grade 3 hydrouretronephrosis. So,
yeah, so case is open for further comments. Was vitamin K given? But just to rule that out. There's no vitamin K deficiency.
Vitamin K was given, sir.
Okay, yeah.
There is cerebellar germinal matrix involvement as well, right? On the, yeah, there is, okay. So I think the first differential would be sepsis, and which could have got worsened with the coagulation disturbance that also could have been related to the sepsis, so to say. I think we will agree here that this is the primary differential in this particular case. Now, agent-wise, mostly viruses would do things like this, but I don't think that's very specific now.
On day 2, day 3 itself, NSG was done, and which was showing some cystic changes by then. And almost this MRI scan was done on day 4, day 5 of life.
Pawan, do you have the CRPs and stuff initially?
CRP initially was around 20-25, sir, which was normal range.
Normal
A
range.
bit more, not.
What is normal CRP in India? We use 5 as a cutoff units
Yes,
wise here.
yes, it's the same here.
So it is high, isn't it?
Not very high, sir, but oh yeah, high.
Can I ask, what is the explanation of the hydrops? I mean, this child had a prenatal severe course, hydrops and intrauterine growth retardation. Was that responsible or the trigger for that later event?
Only one scan, they were saying some hydrops was there, sir. Later scans were showing more of oligohydramnias and IUGR. And there was also severe pH, which was the reason for doing LSCS.
I don't think there's a differential. And Nihaal, you have anything to add? Someone has, Shiji has put call 4A, but I don't think this is a pattern for call 4A or call 4A.
I think it's too diffuse, and they're usually more focal with some insufficient features. What is the plan, Pawan? Getting the thrombophilia workup?
In the prognosis, they went on LAMA, sir. They have sent the thrombophilia profile for this.
Okay.
So,
okay. I think we don't have no further comments. So.
But one has to think of conditions which have both coagulation defect with thrombocytopenia, right? It's not just simple thrombocytopenia. And with hypoglycemia as well. Was the liver function normal?
mild derange, sir. Mild transaminitis
Was the baby dysmorphic? In any
no,
way?
sir. No dysmorphia.
Because CDG disorders can present like this, with coagulation, thrombocytopenia, mild dysfunction, hyperinsulinemic hypoglycemia at birth, the severe forms. So just a thought.
Great. All right, thanks. We'll move on to our next case. Yeah, Dr. A.
So this is a 14-month-old baby who was completely normal till 6-month age, uneventful birth, and then had gradual, so he started to sit and just started to stand at around 8-month age. Rest, cognitive and social milestones were fine. And then has a significant motor regression with predominant low limb spasticity, hyperreflexia. Do you have the did I send a video?
Yeah.
So this is the baby. He's quite alert. He has stranger anxiety, and he has just started to speak 1 or 2 words, babbles. So that's fine. It's more the motor regression. So where he's now spastic, standing in equinus with some knee flexion as well. And when you make him lie in prone position, there is a catch as well. So more of a spasticity low limb. And then
what's his head size?
So his head size is normal for, so he has a relative macrocephaly, but it's still in the centiles. I think it was 75th.
And did it follow after some infection or trauma, I think?
Yeah, so he had, so at 6 months of age, mom remembers that he had a febrile illness, and 2 weeks after that, the child started to regress. So there was no injury, but more like, so I thought clinically more like vanishing white matter disease.
Yes,
Sort
yes.
of,
That's what I thought.
so after a febrile
Because
illness,
they also have relative macrocephaly, not really a big head,
Yeah,
but they may have a
yeah.
slightly.
Sure.
Okay, so we'll move on to the images. And yeah. So on top, you have the diffusion various sequences, and you can appreciate bilateral cavitatory changes involving the bilateral cerebral hemispheres, restricted diffusion in the peripheral aspects of these cavities, confluent areas of abnormalities involving the corpus callosum on both sides, anterior and posteriorly. Predominant white matter involvement in the supratental brain. Some areas of mesotemporal lobes, the hippocampi, demonstrate this area of restricted diffusion. The peduncles also have some foci of restricted diffusion of there. The basal ganglia and thalami are relatively spared. On the flare, you can appreciate the areas of cavitation and rarefaction. More along the peripheral superficial aspects, the corpus callosum does not demonstrate any rarefaction, but you can see that it demonstrates abnormalities, which can be better appreciated on the T2 sequences. Again, confluent white matter abnormalities, central white matter also pyramidal tracts demonstrate these foci of high signal changes. Also, some punctate foci in the bilateral cerebellar white matter. Sagittal images are probably important pointer. The middle blade of the corpus callosum is more significantly involved compared to the inner and the outer blades. Again, you can appreciate the confluent areas of abnormalities on the coronal images. No SWI changes. Spectroscopy demonstrated a lactate peak in the abnormal white matter, in the superficial white matter, and also the central white matter. And also the normal brain parenchyma has a slightly small lactate peak that is in the thalami. Given these imaging findings, the most likely possibility thought of was a mitochondrial discavitatory disorder. This is again a paper for which Caesar is involved, and the main findings are the involvement of the middle blade of the corpus callosum, which is seen in our case. Contrast wasn't given, but restricted diffusion is seen. The deep gray matter symmetrical deep gray matter abnormalities can be seen. Brainstem abnormalities also can be seen, and several peduncle abnormalities also seen. The various cavitatory genomes are listed over here. I'll not go into detail. Just a clue from the imaging for vanishing white matter and mitochondrial disorders. The vanishing white matter usually involves the inner blade of the corpus callosum, whereas the mitochondrial disorders usually involve the middle blade of the corpus callosum. This is again a slide from the recent talk from SPIN 2022 by Dr. Bindu, and she's again listed out the various possibilities, but the common involvement of the middle blade is again noted in all these genes. A note on vanishing white matter demonstrates these areas of rarefaction, but there are no cavitatory lesions, foci over there. And the restricted diffusion is slightly different to what we've seen in our case. That is, the areas which are not rarefied demonstrate a restricted diffusion, whereas in the mitochondrial disorders or cavitatory disorders, the peripheral regions usually demonstrate areas of necrosis, restricted diffusion, which suggests the area of necrosis and high cellular density there. So think of mitochondrial first, and I'll open the case for further discussion.
I think we are all thinking mitochondrial. You can see Aslan and Jaya put it in the chat as well. My question is the next level. Nowadays, when radiologists put mitochondrial in their reports, do they take it to the next level, or are we just, because I have been asked this question in meetings, which mitochondrial? So maybe it's a question for you as well, Nihaal, and for anyone else in the group, because radiologists can be quite defensive and say we don't want to actually go into subtypes, but are you all talking complexes, or and Caesar might help with this as well? Are we going complexes, or are we going to go a particular mutation at this point?
I think it's a very nice question, Kish. If you don't mind, I would like to make some comments about it. I think when we think about and I think we haven't had this discussion before. I think when we are considering mitochondrial disorders, we need to remember that mitochondrial disorders, they may come from nuclear genes affecting the mitochondrial function, or mitochondrial genes affecting the mitochondrial function. So first level of discussion is to divide if there are imaging patterns that may differentiate nuclear genes causing a mitochondrial disorder from mitochondrial genes causing mitochondrial disorder. So since we are considering a complex subunits, causing this disease or nuclear genes causing dysfunction in the complexes. The pattern of white matter involvement sparing the basal ganglia, they make us to think more for nuclear genes causing mitochondrial disorders in the complex 1 and 2 mainly. We also see in complex 4, but 1 and 2 are the most common ones, particularly complex 1. And since the complex 1 is the most common one, and there are several genes that may cause this pattern. We have seen this with EDOFAS1, EDOFAS4, and EDOFAS8, and complex 2. Complex 2 normally is quite variable, but you are showing here in letter E, for instance, the involvement of the middle cerebral peduncles and the base of the pons are very characteristic. For complex 2, you don't need even the spectroscopy to show the succinate peak when you see the involvement of the base of the pons and the middle cerebral peduncles along with the white matter chains. This is quite characteristic. And so I would assume that you need to look for complex 1 and complex 2 and nuclear genes. There are some genes that were already mentioned, the EDOFAS1 and 4 and 8 are the most common ones, but you can also see in other genes. I think the third level, like differentiate the genes, we would need probably a new research with more, a very, very, very large cohort, since these genes are not common and you need a very large cohort to compare each gene for each pattern. So it's not easy to do, but I think it's possible to differentiate them.
Yeah, my intention was to get you to say that actually. Thanks, Caesar. But going back to the geneticists and neurologists in the group, when you request mitochondrial genomics, what is the bandwidth that is screened? Is everything looked under the sun? I don't know is the answer from my perspective.
Yeah, we generally just ask for a group of conditions. For example, you say my cavitating mitochondrial leukoencephalopathy, leukodystrophy. There's a, in fact, in India, there's a higher incidence of this NDUFB1, I think, is a gene which has been regularly described. And the other one we are seeing quite commonly is IBA57 or something. IBS 57, I'm not sure. So these are some of the which are common over here. So maybe you can look at it. I think it's NDUFB1, or I'm not sure. Absolutely. IBA 57, that's right here.
Yeah, that's IBA 57.
Yeah, I also want to make some comments about IBA 57 is very commonly seen with middle cerebral peduncles, and we have seen a couple of cases also of cortical malformations. What's really interesting to know, we had this discussion with Nihaal last week, and they have predilection with middle cerebral peduncle involvement, and we also have a NDUFB1. Actually, we had 3 cases with spinal cord involvement, which is interesting to know that's one of the features that can be associated with this gene. So I really believe that we could be able to divide the patterns as well, but I'm not sure if we haven't yet good numbers to do that. Looks nice comments.
All right, Nihaal, we all agree mitochondrial. We are thinking complex 1 or 2, and we're thinking probably NDUF.
Yeah, the only thing we don't have a succinate peak on the spectroscopy for a complex 2, so does it probably complex 1, I guess?
Yeah, most likely complex 1.
Yeah.
So good evening, Dr. Kavita here. So the question asked was like, how do we, go further into looking at whether something is looking mitochondrial, and how do we further investigate? So when we look at the complexes, I think almost 67% of the all the mitochondrial proteins are actually encoded by the nuclear genes. And if the picture is looking more like, as Dr. Caesar said, the cavitating and pertaining to the complex 1 and 2, then probably it would be better to do the clinical exome to look at the nuclear DNA mediated genes. And if it is like your MRF and CPEO kind of syndromes, where it's the mitochondrial DNA, which is the more commonly implicated, then probably we go in that line first, because otherwise it becomes very costly to do the complete nuclear plus mitochondrial DNA. And as Udani sir said, that if we are having a specific syndrome like a cavitatory leukoencephalopathy and all, still the genetic companies do not do the all the genes implicated for that, whether it is mitochondrial or nuclear. They will either ask you whether you need the clinical exome, that means which will look at only the nuclear DNA genes, or you need a mitochondrial genome as well. So it becomes quite costly. So usually when we are not very sure, we first do the clinical exome, and if we don't find anything in that, and if the syndrome is looking, unless the syndrome is looking very, mediated by the mitochondrial genome itself, we usually land up doing the clinical exome first. And I think my colleagues will agree with that.
Thanks, Kavita. That was very comprehensive. And it's actually useful for us as radiologists to know, because we need to push our boundaries a bit more than in that case.
Yeah, thanks.
All right, thank you. We'll move on to our next case. Yeah, Dr. Rashmi, you can take over.
Yeah. So this is an 11-month-old male child. Actually, they live in Dubai, but they had come to Bangalore on holiday. And the baby was ex-premature, 28 weeks, 1.05 kilos, but they presented with infantile spasms and regression of skills, like West syndrome. So in the history, they were third born of second-degree consanguineous marriage. One sibling, sisters in good health, and there was one previous abortion. Baby was born by LSCS 28 plus 1 weeks and had a NICU admission after birth, was ventilated, and was in the unit for about 2 months. Development-wise, they have a little bit of mild developmental delay, neck holding 5 months, rolling over 9 months, sitting with support 9 months. Since the onset of spasms, the baby was not sitting and cranky and was babbling. The tone was normal and there was global developmental delay. So the EEG initially showed electrodecrement consistent with infantile spasms. The other basic blood tests were normal. So I started the baby on high-dose steroids according to IKIS. But within a week, the spasms didn't stop. So I added in vigabatrin and also doubled the dose of steroids, and the spasms completely stopped. The baby became less cranky. Then I weaned off the steroids, and the vigabatrin is now continuing. The baby was on vigabatrin for 2 to 3 weeks when this MRI brain was done.
Okay.
So this is the story with this child.
Sure. Okay. And on the MR, you have symmetrical areas of restricted diffusion in the bilateral globopallidi, subthalamus nuclei, and also in the pyramidal, the brainstem tracts and the central tegmental tracts on both sides. Some degree of volume loss in the supratemporal brain parenchyma. Again, faint hyperintensities involving the corresponding to the diffusion changes. Sagittal cannot appreciate anything, maybe slightly reduced corpus callosum, but other than that, no other findings. Posterior fossa structures are normal. Spectroscopy cannot appreciate any diagnostic peaks which contribute to this case. So based on the clinical history, first possibility we thought of was a vigabatrin associated toxicity. Though they are usually present in the course of medication is slightly more than the 2 to 3 weeks period, but there are cases which are presented with these changes. As example, here this case was presented with these bilateral changes for a period of 1 month, and over here this child had changes in 36 days. So the imaging findings are pretty similar to what we've seen in our case. Again, the differentials are wide for the non-vigabatrin-related toxicity changes as discussed earlier. Again, central tegmental tract hyperintensities, again, large differentials, but West syndrome and vigabatrin is one of the differentials for that. Another less likely possibility, though, to be considered is the PIGA deficiency, which also has the symmetrical central changes, but the clinical findings are slightly varied. They have usually elevated alkaline phosphatases, contractures, cardiac abnormalities, and hearing loss and tone issues. So at this point, I'll open the case for the panelists to comment on.
In terms of prevalence, things are common, should be first considered. And I think the likelihood that this is due to the medication is very high. I would wait and see and not spend a lot of money for genetic investigations. This is classical within a month.
Okay, but it's only 2 weeks the baby was on vigabatrin.
Yeah, but most papers, I mean, unless you do online MR, you don't know exactly when it starts. At least it can start within a month, maybe in 2 weeks. Why not?
Yeah, I don't think 2 weeks takes us away from the dose-dependent effect of vigabatrin.
It's a very, yeah.
Mm.
Sorry.
Can you just go back one slide? Sorry, Vivek, I interrupted you. Carry on, Vivek.
No, I think it was Dr. Rajesh. Rajesh.
Yeah, Dr. Reddy.
Yeah, sorry. No, I mean, you finish, Kshitij, there's no issue.
No, I was just saying that Eugen is right. I think we would give that as a primary differential here in terms of vigabatrin changes. It is dose dependent. I'm not sure what dose you had started them on. And
I started them according to the IKIS protocol. So
okay.
that's the dose.
The only thing is we would not, and we should not report this as toxicity. It's just vigabatrin associated brain changes, right?
Yeah, it's interesting that this syndrome basically initially was thought to be almost asymptomatic, and of course it's completely reversible. But I think we've seen a couple of cases. Our first cases was a child who was extremely drowsy and became dystonic. And the MRI, the first MRI was normal. The second MRI showed this. At that time, it was not been described, this vigabatrin. So obviously, in many patients, it is asymptomatic and it doesn't give any problems. And I think many people don't consider the necessary to even stop it if there's no issue. But I think in a severe case, if you have symptoms, you should definitely stop it.
The baby is actually improved on vigabatrin, and I was planning to give it for 3 months, and then
a smaller dose, I suppose.
Oh, just reduce the dose. Okay.
Dose dependent, yes.
Okay. Yeah. The other thing was there was also pre-existing developmental delay. There's consanguineous marriage. So many other things. Initially, I thought it was just prematurity related. I didn't expect the MR to come up because there's a degree of what they said was the brain is a little bit small, which may be, I think they measure the how much diameter is there, no?
It's slightly atrophic, but I wouldn't go by the.
Okay.
So Rashmi, have you ruled out biotinase deficiency?
Yes, TMS and biotinase was normal.
Okay, because we had a similar case. In fact, this baby had meningitis in the newborn period and then had recovered and started with spasms. And on starting vigabatrin, he developed encephalopathy and these kind of changes on the MRI. And so we were very happy to diagnose it as vigabatrin-induced changes. And because we had sent a TMS and all, he surprisingly had a very mild rash, and that's why we said that let us just rule out, underlying any metabolic disorder. And he had actually biotinase deficiency. So yeah, but your case, you have said that it's already normal.
Yeah, but the thing is, I have sent genetics in this case, and I've just started the baby on thiamine and biotin. I don't know how much it'll be useful, but I've just started it. I thought let's wait and then see.
Okay. That child then improved on just biotin, and we could omit everything later. So in fact, the infection and everything probably was related to the underlying metabolic deficiency.
Okay. It's very interesting. Thank you.
Yeah, thanks.
Kavita, your patient's changes could still have been due to vigabatrin, even if he had vigabatrin.
Yeah, that's what we thought, that this encephalopathy is because of vigabatrin only. But usually we first, just omitted it, but he still did not improve to that extent. And the spasms also continued. And that's when he started having a little bit of a non-specific rash in the axillae and all. It was not really very bad rash. Yeah,
that's fine, Kavita. What I'm saying, those changes which were there in the MRI might not necessarily be biotin. They might have been due to vigabatrin, even if it works or not. So you cannot use, one cannot say that this pattern can also be seen with biotin deficiency because your patient was on vigabatrin.
Yeah, I don't remember the exact areas involved, but it was the basal ganglia, and whether the tracts were involved or not, I'm not very sure right now.
Could I ask the radiologists what in biotinase deficiency, if I remember right, the prick is involved? I mean, is there a slight, can you just tell us what the changes in biotinase?
Yeah, what would be the difference in those changes?
Yeah, I'm just confused now. We are talking biotinidase or biotin thiamine deficiency because the supplementation.
No, biotinidase.
Biotinidase. So this is not typical picture for biotinidase based on the X number of cases we have seen. First of all, the imaging can be completely normal in most cases, but if there is abnormality, then you have various other manifestations of it. This is very typically the vigabatrin related changes that you see. The only thing, and I was trying to text Nihaal, is in this, there is an underdevelopment of the brain in the background. Take the signal change away, but those frontal lobes are a bit underdeveloped. So there could be another reason why this child is having whatever they're having in terms of, is it spasms or epilepsy? I forgot the first slide again. But you might still find something else in the background. If we take our focus away from the acute changes of vigabatrin, there could still be an underlying problem in this particular case.
Yeah, that's why I've sent off the genetics and started on thymine and biotin.
Though they were premature, though they were premature at 28 weeks. But again, I don't think this is biotinidase deficiency. We have just about recently put together an international cluster, and some people from India have contributed cases as well. None of the cases look like this. Happy to share that manuscript when it's rolling.
Sure, thanks. As Vivek said, it may have been vigabatrin induced only. But I'll have to dig in and again find out what exactly were the changes.
So generally, we just reduce the dose slightly, is it, when you see changes like this?
We actually completely stopped it because the baby became encephalopathic.
Your baby became, but my baby is improved. This baby is improved.
Okay.
So, okay.
I don't know if reducing the dose is actually the international recommendation for vigabatrin associated changes. I'm straying away from radiology totally here, but I'm happy to stand corrected.
I'll have to look into it, but personally for this child, since it had improved the spasms, I did not do anything. I said, we'll take it off anyway in 3 months. I mean, it's almost a month now. So, I don't know.
Okay. Yeah.
The thing is this, the ICAS trial says that you have to starting vigabatrin and steroids is more effective than just steroids. But what I found was with vigabatrin, they become very cranky. So I start high dose steroids, and if they don't improve, then only add in vigabatrin, which is what I did in this case. So yeah, let's see. Yeah. Anyway, it was a nice discussion. Thank you very much.
Yeah. Thank you. Next 2 cases are from Dr. Kavita. Brahmani is there, she can probably present the case.
Yes, sir. Good evening, everyone. So this is a case of 11-year-old boy born out of non-consanguineous marriage with normal birth and developmental history. At 3 years of age, he was found to have left testis undescended, and there was also a swelling on the lumbosacral area. So for which they have done an MRI, abdomen and spine, and then they incidentally found there was a tethered cord and diastematomyelia with syrinx. So for which he underwent detethering of cord also. Actually, unfortunately we don't have those previous images. So I mentioned the report here that the report was there. It showed that there is a spina bifida at S2 level and butterfly shaped vertebrae noted at D6, D7, 8 levels, and brain is also showing mild cerebral atrophy, right more than left. So for these complaints, he underwent laminectomy and detethering of the cord. Since after that, the child was normal. He actually never had any bowel bladder involvement or lower limb weakness prior to the surgery also. Retrospectively, the father said there were occasional falls, but they didn't notice any weakness as such. Post-surgery also, child used to complain intermittent dull backache, but it never disabled him. He used to play normally. Now at 11 years of age, he came with the complaints of acute onset of bilateral upper limb weakness since 3 days. Like there was a difficulty in lifting both the arms above the shoulder, and also there is a difficulty in holding the objects associated with tingling sensation. And on asking, he said there was a backache and neck pain also. On past history, prior to these complaints, there is a history of fever with cough and cold 7 days prior. So with these complaints, we have admitted the child and we did an imaging. On examination, there were no cranial nerve deficits, sensory wise, higher mental functions were normal, but motor wise, there is a flat tone in the bilateral upper limb and mild spasticity in the lower limbs. Power wise in the upper limb 2/5 and 4/5 in the lower limbs with hyporeflexia. So images, sir.
Any eye abnormalities, any complaints of vision?
No, sir. No, it's completely normal. No involvement of vision at all.
Okay.
So it's like a central cord syndrome, right? Central cord syndrome.
Yeah. more because of the upper limb more involved. But in a history of fever 7 days prior. So
Okay. All right. We'll go to the images and get back to discussion. So on top we have the FLAIR non-contrast sequences. No focal lesions in the bilateral cerebral hemispheres, the white or gray matter. There is a tiny focus in the dorsal aspect of the medulla. But other than this lesion, I could not appreciate any focal abnormalities. The cortex is slightly hyperintense, but I'm not sure if this is a normal signal of the normal FLAIR sequence signal of the center. No diffusion changes on the FLAIR in the optic nerves. The optic nerves slightly hyperintense, almost involving the entire tracts. We can also appreciate that there is some fat standing in the bilateral optic nerves on the coronal sequences, left more than right. I think contrast wasn't done for the brain. Spine changes. You have these areas of restricted diffusion involving the area of the abnormality on the medulla and also the cervical cord. The short segment involvement showing the T2 hyperintensity and slightly swollen appearance. There was a syrinx in the dorsal aspect of the spinal cord, which corroborates with the axial images. The cervical cord images predominantly involving the gray matter, this typical head-shaped appearance, and the split cord malformation in the lower lumbar spine, where tethering of cord is demonstrated on the sagittal and the axial images. Based on that, possibility of demyelination or parainfectious etiology is to be considered. Thinking of MOG antibodies and ADEM or the MOG ADEM phenotype, though for ADEM there is no, the parenchymal changes are absent. The central gray matter involvement can be seen predominantly in the MOG antibody-related changes of the spinal cord. They can present with short segment or long segment involvement. It can also have these bilateral optic nerve changes. So these are the differentials we're thinking about, and I'll open the case for discussion.
Sir, is there involvement of area postrema in this child?
Yeah, it involves with that.
Yes.
That suggests NMO, no? But of course, it's a short segment, but still
Yeah, it's a
NMO
short
should be
segment.
also ruled out. You still
Yes,
rule
sir.
it out.
Are we sure that the area postrema is actually involved? It's close to the area postrema, but has the child presented with vomiting?
No, sir, only bilateral upper limb weakness.
But NMO can come with dorsal brainstem. I mean, it doesn't have to be coming. I mean, it's what's it called? It's a brainstem syndrome. And if you look at the optic nerves, are more posteriorly affected or more anteriorly?
Yeah, more posteriorly and the mid segment.
That goes more in favor of NMO, right?
What's the age of the child?
11 years.
And we have sent NMO MOG, both are negative, sir.
I will reserve. I think this could still be MS, right?
There are no visual symptoms as such.
I may have missed the point. Any visual complaints? Any?
No, sir.
No, sir. No visual complaints.
Could be infection.
So first of all, we are all agreeing this is inflammatory, infective. So we are going to ask you what the CSF showed. Or did you just do the MOG without doing the CSF and stuff?
Yes, sir. I mean,
Yes, CSF was not done.
it's not done.
Again,
just
this
trying to
optic
read the
nerve
story
involvement.
There were too many things, laminectomy done and, tethered cord and all that. So we didn't really do the CSF here. And we were not suspecting any acute infection as of now. Of course, post-infectious or inflammatory lesion was the first possibility. And because of all the spinal surgery and we don't know the anatomy of the cord properly, with still a tethered cord there, we didn't want to do a CSF. Yeah.
Actually, might be easier to get CSF because there's been surgery out there. You have a soft tissue window.
Yeah, but the cord is still ending lower, so we were not sure, where to go in.
Is the optic nerve involvement convincing? Is this it's because if the optic nerve involvement is not convincing, then one again has to in life go by one illness only, like we are thinking of two illnesses in a child who already has a significant spinal cord issue. And his spinal cord axial image showed diffusion restriction. Is that right?
Actually, you're right. I was actually thinking of when you were discussing the case in the beginning, I thought, is it a vascular problem?
Yeah, vascular problem.
But the problem was that then there was a lesion in the optic nerve and a lesion in the brainstem, which also makes it very difficult to have an anterior spinal artery syndrome over here.
But the lesion in brainstem is also restricted actually. So that's because when you see it in the axial image, in the sagittal spinal.
You're right. But
and optic nerve involvement looks very suspect. Like you're sure, Nihaal, there is optic?
Yeah, I'm sure, but I would prefer a contrast just to be honest.
So clinically, there is no visual symptoms, but of course, we have not done a VEP, and the child is big enough to tell actually about any visual complaints. He's 11 years old. So the only complaints were bilateral upper limb weakness. Sorry?
No, but visual complaints may not be there in patients who have subclinical demyelinations. MS, it happens all the time. In the past, we used to do, before MRI, we used to do VEPs as a kind of marker for dissemination in space.
So, Nihaal, I missed out the diffusion of the spine actually showing restriction in all these areas, right?
Yeah.
And what is the timeline from spinal surgery compared to this presentation?
3 years.
Surgery done at 3 years of age.
So it's many, many years, right?
Yes,
so
sir. 8 years.
It's not recent surgery.
No.
Yes.
But diffusion restriction in any of these inflammatory conditions, I'm just trying to think aloud here because the possibility of vascular was raised. Now, if it's vascular, it's at least 2 levels, which is quite unusual, right?
Yeah.
And it's very remote from the surgery, so we can't call it iatrogenic vascular insult either.
And there is
a swelling also. Is it a myelitis rather than an infectious myelitis?
Not many of them restrict instantly like that, but infection inflammation is what we are thinking right from the outset. You need to do a CSF at some point, I think.
Can I ask a question over here? I mean, is it when you do diffusion in the brain, you always look for ADC, darkening on ADC.
Yeah.
Over here, we don't have an ADC. So how does this is not T2 shine through?
Because we trust Nihaal has seen the ADC.
I'm asking.
Can I ask, the lesion in the brainstem is in the area postrema, isn't it? So this is a strong argument in favor of MOG and against MS or whatever, relative arguments.
I assumed it's a little bit higher for that. But
yeah, it's not area postrema.
Yeah, it should be somewhere here. Yeah, it's slightly higher. Yeah, probably somewhere here.
Dr. Caesar saying something. We're not able to hear.
He was agreeing with me that it's not typically area postrema.
Okay.
Sorry.
There's one question. I think it says, is it optic perineuritis? So it's an interesting thing because that's very typical for MOG.
I'm not convinced about optic perineuritis in the absence of any optic signs, to be honest. Sorry, Nihaal, I don't agree completely. We don't have a clinical correlate of those optic nerve changes you are showing.
We will get a VEP done and try to see whether there is really any affection. But at least clinically, there is nothing.
Somebody's talked about enterovirus myelitis.
Yeah, if you remove the optic nerve changes, yeah, it's possible.
So the child actually improved after methylprednisolone and now is still left with the residual, like it's been just 1 week and there is still a wrist drop on the left side. So there is a distal weakness still persisting. Rest of his power has improved considerably.
And Vivek will kill me, but I think it has been the day of dual pathologies today, isn't it?
Okay, so we'll get a VEP and possible CS.
Yeah, actually, we were very surprised because the child has underwent spinal surgery and all that.
Okay.
And we were just thinking that it must be related to that. But we were quite surprised with the MRI findings, actually.
There is one concern I have. I know you haven't done a contrast study here.
Yeah.
If there has been an infection in the surgical bed around wherever they have had their operation and stuff, And if you start picking up a lot of leptomeningeal enhancement in the cord, that might be relevant. So you might want to consider doing that to cross off that, because you do have a substrate there for infection, even though it's quite remote.
The surgery is not, it's pretty,
But
I think
it was
8 years back.
done at 3 years age. Yeah.
He's
Yeah,
11
but
now.
nothing in the local skin and all that, right? In that area.
No,
No, sir.
nothing.
So we wait for the MOC results and perhaps for a follow-up study.
Yeah.
So MOG is
maybe
negative. MOG and
formal
NMO
vascular
antibodies
imaging?
are negative. Yeah. Sorry?
Maybe from formal vascular imaging as well.
No, we have not done.
Okay.
Okay.
Okay, we'll do that. So MOG and NMO antibodies are negative.
Maybe you
And
can do.
but
Maybe you
we
can
did
do.
treat it as antibody negative demyelination, and the child is also responding. I don't know whether it's spontaneous or on methylprednisolone.
Infection is still a
What about-
possibility.
Is it possible APLA? APLA can give extra myelitis.
Okay, sir, we have not thought about it.
Okay.
We'll do that, sir.
Thank you.
NMO,
Yeah.
VEP and APLA antibodies.
Yeah.
Thank you so much.
All right. Yeah, thanks. Next case, Pamani.
Yes, sir. So this is a case of 6-year-old boy with normal birth and developmental history. He came with the complaints of sudden onset of left-sided tonic posturing of only upper lip, which lasted for 5 to 10 seconds. And these similar episodes occurred in a cluster of around 6 to 8 times over 30 minutes. So on 5th of August. So on 5th of August only first time he had this kind of cluster, which lasted, each episode lasted for 5 to 10 seconds only. And after that, he was admitted outside. He received some anti-seizure medications and he was doing well till 9th of August. No symptoms, nothing. On 9th of August, again, he had a similar episode of the left upper limb and lower limb, followed by he had left-sided weakness. There was a decreased consciousness following GCS and also the child was immediately shifted to our Bharti, and mother also noticed that there is a paucity of movements on the left side upper limb and lower limb. And we saw there is a left-sided facial palsy, UMN palsy. So this child was admitted in PICU, intubated, and we did a stroke workup also. Initially we did a CT followed by MRI.
Yeah. So CT done 2 days apart. You can see that there are some changes of chronic ischemic change in the left periventricular region on the anterior and posterior aspects, some degree of volume loss, some hypodensity again in the right frontal region, and again some areas of chronic changes in the right parietal region. The frontal horns are slightly dilated or prominent. No other abnormalities in the posterior fossa, at least on this plain CT. CT scan done 2 days later, directly go to the MR because it was done on the same day. So the MR, you can appreciate that there is a subacute infarct involving the right frontal parietal regions, predominantly involving the MCA territory. Also, you can appreciate the chronic ischemic changes in the left cerebral hemisphere. Corpus callosum is slightly thin and broad anteriorly and superiorly. I think contrast angiography was done, and you can appreciate the lenticulostriate collaterals, also collaterals in this circle of Willis. And on the MIP images, you can appreciate that there is narrowing of the bilateral ICA, terminal ICA, and the lenticulostriate collaterals are clearly visualized. Neck angiography did not demonstrate any abnormalities. ASL was done, and on the ASL, you can appreciate the degree of hypoperfusion in the right cerebral hemispheres involving the area of infarct. Some areas in the left anterior frontal region, but the predominant changes are in the right frontal, parietal, and temporal regions. Dr. Kavita, I think, was asking what was the question? I'm not sure. It is a Moya type pattern that is at least on a radiologically diagnosis. But the question was on the ASL, if I'm not mistaken.
Yeah, we wanted to know what is the relevance of ASL here, like in maybe your routine MCA strokes and all, it's fine. But here, does it help us to decide, like now right side is already infarcted. So left side, does the ASL help us to decide whether we need IDAS on that side, or like, how does it help in the planning the therapy?
Dr. Mangad, wouldn't like to take that up? So we don't do ASL here, at least frequently for Maya. As far as I know, when the revascularization procedure is done, they do an ASL immediately or within a week's time, and they can see that there are immediate changes of hyperperfusion. And in about 3 to 6 months, the changes will stabilize on the affected side, at least in literature that is mentioned. I'll open the case for the panelists to answer the question.
Yeah, I agree with you. And I think also in this case, you've done very quick ASLs after the procedure, right?
I don't think a procedure was done.
A procedure has not yet been done. It is
Yeah,
planned.
okay.
First they need a DSA. The neurosurgeon has asked for a DSA, and then they will do the IDAS or bypass. He's a big boy.
Yeah.
But we wanted to know what is the utility of ASL here? How does it help in deciding which side? Obviously, now there is a fresh infarct here on the right side, so that is going to be showing hypoperfusion. But in a routine case of moya, does ASL help in planning which side to go in if it's bilateral?
Yeah, I think to summarize, it'll be better, Nihaal, if we share the paper that has been published by the Melbourne group on this, as well as I think Boston may have done something in terms of how they have used ASL for moya. And I think it's still a big discussion as to whether it's ASL is good enough or it's DSC perfusion with Diamox and things like that to establish indications for surgery. I don't think we can give an instant answer based on one picture, which is showing an obvious difference in the perfusion between the two sides.
Yeah, the only con of ASL is they say that because of the collateral, they can be slow flow, slow exit. So it can be an overcall on ASL rather than a DSC perfusion contrast image.
So any other comments from Dani sir, Vivek?
We don't do ASL generally because we don't have the software. I think, I don't know why they don't do it, but I think that's what makes a lot of sense. I mean, I didn't know this, but I think somebody mentioned that it's a very good thing to do after surgery. And maybe that will help to sort of monitor the perfusion changes which occur. Am I right? Somebody did mention that.
Yeah, they do it after surgery.
Yes.
And
yeah. The only thing is, I mean, we don't normally do DSAs in a case like this. Just go ahead and do, unless you're thinking of a direct revascularization. Otherwise, if you're doing an EDAS, that's what most people are doing nowadays. Is there any
actually, our neurosurgeons always insist for a DSA. We were also asking the same question. I mean, we are not thinking of a bypass immediately. And for EDAS, why do you need that? You're just inserting a temporal muscle flap. But they just want to know the anatomy in detail before going in. So we were very fascinated with this new technology that we have, but we don't know what to do with it. That's the reason I wanted to know, how can it help us in taking any decisions?
There's a comment on the chat. Yeah, site of surgery can be ascertained by the perfusion changes. If there's hyperperfusion and the brain looks relatively okay without any parenchymal changes on the diffusion, then it's an indication for intervention on that side.
I agree with Rahul, what he's put there. But we're not doing ASL ourselves. We do a DSA because they would see that and proceed in terms of revascularization surgery. But at baseline, it's going to obviously show a reduction, as in your case, Kavita, given that there is stroke on that side as well.
Yeah, so we just want to right now salvage the left side, as soon as possible, as soon as he is a little stable. The question was for a case where we may not have such a big stroke and we just diagnose moya, how does ASL help in deciding which side to go in first? So that this is the question that we wanted to actually discuss.
This what they do in I think Toronto is they basically do some CO2. I don't know. Is it they use CO2 to see the whether there's any need for urgent revascularization? Anybody aware of that? Exactly how they do that procedure and all? It's done by anesthesia. It's supposed to be very simple compared to doing Diamox and all, because you require IV Diamox.
We can get the exact protocol from them. I had seen Dr. Shroff on the meeting, but I think he's since left, or is he still there? Unless he wants to join in and say something. He's still here.
Yeah.
Okay, thank you very much.
All right.
Nihaal, if you can share that paper as well.
Sure. Yeah.
Okay, thanks.
The next two set of cases are from Dr. Kamte. Dr. Kamte or one of the fellows want to take over the case?
Yeah, this is a 1-year-old male child born of third-degree consanguineous marriage with a global developmental delay, and is not turning head or light to sound, head to the sound, and has history of generalized myoclonus since last 1 month. On examination, has axial hypotonia with lower limb spasticity with scissoring and dyskinesia in all 4 limbs. So this child's actually on clinical examination, the TDs it was suspected included any intrauterine torch infection, cerebral malformation, and MRI was done to see for the to confirm a diagnosis, and it showed the following.
So the following MR, we have the axial T2 weighted sequences, and you can appreciate that there is agenesis of the corpus callosum of the corpus callosum is severely hypoplastic with a widened interhemispheric fissure, some degree of prominent pericerebral spaces in the anterior and lateral convexities. Basal ganglia and thalami are normal, dysmorphic appearing lateral ventricles, predominantly in the trigones and the occipital horns. Probably some reduction in the white matter over there in the posterior temporal and occipital regions. Brainstem on axial images is demonstrates reduced volume, as you can corroborate with that on the sagittal images. A severe reduction in the volume of the brainstem and also the vermis and cerebellum. The vermis is more severely affected as compared to the cerebellum on the coronal images. Again, some dysmorphic appearance of the lateral ventricles with reduced white matter volume. Cannot appreciate any abnormalities on the SWI sequences. So this is again differentials could not come to a specific one, but this is paper from Dr. Balthazar. We'll probably have his comments after the discussion, after I present the differentials. So corpus callosum abnormalities can be seen in the pontocerebral hypoplasia pattern in these disorders. PCH9 was raised as a possibility. The axial images did not clearly demonstrate the figure of 8 appearance as we commonly see, at least to my eyes, on the lower mesencephalon. Callosal abnormalities are commonly seen in PCH9, and the child also had dyskinesia, which is also commonly a pattern in the PCH9 variant, but the imaging, I think, probably did not match. The PCH TSN54 was another possibility, but in TSN54, it's a dragonfly pattern where the cerebellar hemispheres are more commonly affected, severely affected in comparison to the vermis. Callosal abnormalities are not commonly described. So I'm just showing this because on the whole exome sequences, it came out for a TSN54 intron heterozygous mutation of uncertain significance. These are again from the Dr. Balthazar's paper, and clinically and radiologically, you can appreciate the different findings. PCH2A only is the one which has extrapyramidal dyskinesia, and the child also had dyskinesia, but rest of, I don't think there was any history of polyhydramnios, which is commonly seen in 4 and 5. Tubulopathy was another possibility raised on the spreadsheet, but the basal ganglia, as seen in our case, is normal, whereas the basal ganglia are dysmorphic in the tubulin-related disorders. Posterior force abnormalities can be seen, which are not seen in our case. There can be some axial asymmetry. So I'm not certain of a diagnosis, and I'll open the case for the panelists to comment upon.
If I want to make just one question, one comment.
Yeah.
We also have one saying with a similar appearance, like was found this gene, but with a lot of malformations, including malformations in the brainstem without classic appearance of the same 54. What's weird for us, but we have seen at least one case I'm remembering now that was quite similar to the case that you are presenting, and the question was exactly the same. Could we blame the gene for the imaging findings that were less degenerative findings, but more formative features? Although in our case, I see also some white matter chains and other So just hoping that we have already the same discussion before here and we didn't find a final conclusion.
Can you please clarify the genetic result? Is that variant found just on one allele? You mentioned heterozygous. Does it mean it's on one allele or is it compound heterozygous?
So this is actually located on intron 10. So it's an intron mutation and it's found heterozygous, although the inheritance is autosomal recessive. So it's
so this is on one allele.
Yes.
So it doesn't explain so far the situation. This is a recessive gene.
And we were checking if the tubulin genes for tubulinopathy were covered. So only the TUB-B2A gene has not been covered. The rest of the genes were covered. So whether it could fit into a TUB-B2A mutation.
No, I'm thinking more a microtubulin activated protein rather than you've got the whole map spectrum. You might need to do a little more. This is not typical PCH according to me.
PCH plus. Dr. Kamte, any comments or questions?
That's what actually, Nihaal, we thought we'll ask for reanalysis to look for the microtubulin genes. Because PCH they had thoroughly checked out and it did not fit into one of these PCH genes. So because we felt that anterior limb of corpusculosum, anterior limb of inner capsule was not very well seen. So we thought more in terms of tubulopathy only.
Actually, this is from your case. This is actually from the case. I would say it's reasonably okay. But yeah. What was the age? Sorry. 1 year.
1 year.
But they're usually more dysmorphic. I mean, they're a little more bulky and the frontal ones are usually more abnormal because of the. So, maybe a reanalysis and answer.
Yeah, we will give that further clinical details and get a reanalysis done. Thank you.
All right, thank you. Yeah, next case.
So this was an 18-month-old male child born of consanguineous marriage with a history of delayed cry at birth and a history of PROM. There was an NICU admission for 3 days with history of hypoglycemia and polycythemia during the neonatal period. The child presented with global developmental delay and dyskinesia in all limbs. The head circumference was normal. We have a photo of the child which shows mild coarse facies and thick eyebrows, and there is a flat nasal bridge. We had got a first MRI done which showed mild thinning of corpus callosum, and clinically we suspected MPS or mucolipidosis. Urine glycosaminoglycans was negative. We have the second MRI images now.
Sure.
Why can I jump in? Why did you ask for urine oligosaccharides? Is that your routine or you have a special suspicion?
No, sir, actually that is, we initially got urine glycosaminoglycans, and then based on the whole exome report, we got this done later.
Okay, so this is reverse metabolic finding, is it?
Yes, sir. That was the heterozygous mutation seen in Naga gene.
Okay. Yeah.
Which was autosomal recessive, and then we confirmed urine oligosaccharide levels after that.
Okay.
So you should mention this on the next slide. I mean, kind of in terms of
I think
of course.
I think that's my mistake. You can. Yeah. Sorry. So yeah, the imaging we have multiple patchy areas of subcortical, extracortical hyperintensities in the bilateral frontal lobes. They look slightly thickened and simplified. I'm not sure if the other members agree, especially in the frontal regions over here. The gyration is not normal, at least to my eyes. Corpus, again, the ventricles are slightly abnormal. There's a posterior prominence of the lateral ventricles. No other areas of cortical malformations or focal lesions. Again, these are thin-cut T2 fat set images, and you can appreciate the patchy white matter hyperintensities a possible gyral abnormality, though I'm not very sure of that. Again, parietal region also demonstrate these hyperintense changes. Posterior fossa, this is actually artifactual, not real. It's not present on the other sequences. The cerebellum does not demonstrate any dysplasia or signal abnormalities. Corpus callosum is slightly dysplastic. Maybe there's reduction in the size of the body of the corpus callosum. No diffusion changes. Spectroscopy was done, and it consistently demonstrates a lactate peak. The rest of the peaks are normal, no diagnostic significance. So I think we'll go to the gene first. I think this was the gene which was found, Naga gene of compound heterozygous mutation with a VUS variant. And I think after the gene was found, it was sent for urine oligosaccharides. Is that right?
Yes.
Yes, sir.
Yeah. So these are the different, again, the abnormalities which can present with elevated oligosaccharides in the urine, predominantly lysosomal disorders. I could find only, I think, one case with the gene findings. It had a pontine hypoplasia, abnormalities of the corpus callosum, some malformative changes, dysencephaly type changes in the bilateral cerebral hemispheres with the microcephalic head and facial dysmorphism. I haven't come across this gene, and so I'll open the case for any others who have come across this gene or imaging findings or clinical findings.
Well, congratulations, you made a final diagnosis from a clinical point of view. And of course, also in my setting, the question is whether you start initially with genetic investigation, which is in our area complicated and takes a long time, or whether you start with metabolic screening, amino acids, organic acid, GAG, oligosaccharides, sialic acid, and so on, purine, pyrimidine, and often the yield is comparatively low, but you see that from time to time, simple oligosaccharide screening urine can detect a number of conditions, and you have the result immediately, I mean, in a few days. But you have achieved the diagnosis very well, and this is a rare condition, Schilder's disease.
I have a question. If you did not have the clinical picture of dysmorphic faces and all that stuff, and you saw this MRI in a non-specific delayed child, what do you think of with those subcortical changes, with the little gyral abnormalities? What do you think of, torch kind of infections? Would that be, what are those hypointense lesions in the cortex? I mean, are they calcium or something or what?
No, they're not calcium. There was no abnormalities on the SWI. For torch, especially CMV is a possibility, but they're usually more posterior predominant and anterior predominant abnormalities. But still, I would rule out a possibility of a congenital CMV there. If there were total abnormalities, then possibly murosin negative muscular dystrophy, but I don't think clinically the child has any changes related to CMD. They can be possible prominent perivascular spaces on a thin cut section on a flare, which can be commonly seen in the lysosomal disorders, but I wouldn't be very specific on that. So yeah, I will not be able to point on to a differential on the MR, though congenital torch is a possibility.
These changes are completely non-specific, non-diagnostic.
Yes.
That's good. Yeah, thanks, Dr. Kamte, for a new gene, at least for us.
Trying to get the parental testing done. We have spoken to parents, sending the sample of both the parents for segregation analysis. Once you get the results, we'll update. Thank you.
Sure. Right. Thanks. This is our last case. I'm not sure if Dr. Sunita is there. Okay, I can't see her online, but yeah. This is a case of a 1-year-old child who presented one episode of seizures and developmental delay since the age of 3 months. I think the imaging and the clinical treatment aspects are pretty important over here. This is the initial scan demonstrating generalized reduction in the brain volume, predominantly in the supratemporal brain volume. Corpus callosum also demonstrates reduction in size. There's some hypopulation or reduction in the size of the brainstem. The cerebellum demonstrated relatively normal appearance. No focal signal abnormalities, no cortical malformations. So this is a follow-up after 2 years and 6 months. The child underwent some form of treatment or medication, and and Aslan is right. She was on vitamin B12. So the changes are completely reversed on therapy of supplementation of vitamin B12. And you can see there is now the brain volume is normal. There's no changes of atrophy. So this is just in comparison. This is the present MRI 2.5 years later, and this is the initial MRI which demonstrated significant atrophy. I think Dr. Kamte, yeah, I mean, at least I remember seeing many cases of vitamin B12 deficiency with reversal changes.
You're right.
I think that's
it's quite a common scenario with us.
Yeah.
So I think in every case of NCL or any gray-matter digital disease, we should rule out vitamin B12 in our setup. Like.
Yeah. I think her question was what causes the atrophy and again neurodegeneration. I think vitamin B12 plays a role in neural regeneration, so that could be a possible explanation. And the Whitaker trial also demonstrated changes where vitamin B12 was supplemented and the atrophic changes were reversed in these areas, almost involving the entire supratemporal brain parenchyma. So yeah, it's an important finding so that it can be easily treatable and probably not go into genetics. So I think that's our last case. Follow-up cases from Dr. Lokesh, but I don't think he is available. So we'll discuss them in the next session. The next session we'll just give you a date because the pediatric neuropedicon is on the same dates. So I'll reschedule it and update you on the various social media platforms and probably email you. So thank you everyone once again for your expert opinions and discussions.